I'm Bob Barish, the Vice Chancellor for Health Affairs at UIC, and in this role, I oversee UIC's Academic Health Enterprise, or UI Health. So our health system is indeed distinct across the nation in that we unite the environment of our healthcare delivery network, which includes a tertiary care hospital, over 40 outpatient clinics, and 11 federally qualified mile-square health center locations, alongside the discovery and training of UIC's 7 health science colleges and units like the University of Illinois Cancer Center. Together, we provide over 1.5 million visits, train the healthcare leaders of the future, and make discoveries that benefit our communities locally and around the world. So it's a pleasure to have this opportunity to open the program that combines the Chancellor's Chair Chat series with our own UI Health Distinguished Scholar series. The Chair Chat series brings well-known leaders and influential visionaries to the UIC community to explore powerful ideas for an equitable, vibrant future. Through engaging conversations on crucial issues, the series' intent is to foster connections and access educational, research, and clinical excellence, in line with UIC's mission and role in shaping the future in Chicago and beyond. The UI Health Distinguished Scholar Series was launched in 2020 and has grown to include units across the enterprise. The series provides an opportunity to learn from nationally recognized healthcare leaders how they think, why they pursue their vision, and how to apply their insights to improve health. So what better way to combine these two concepts but through an intimate discussion with Dr. Robert Califf. Dr. Califf has long been a driving force in clinical research and public health policy. Twice appointed Commissioner of the Food and Drug Administration, first in 2016 and again in 2022, he led the FDA through transformative periods in healthcare. Between these roles, he guided strategy at Verily and Google Health, advancing digital health innovation. At Duke University, Dr. Califf served as Vice Chancellor and founded the Duke Clinical Research Institute, one of the world's leading academic research organizations. His work has consistently championed equitable access to care and greater diversity in clinical trials. These principles have shaped national policy and inspired DEI change across the field. A member of the National Academy of Medicine and author of more than 1,200 peer-reviewed publications, Dr. Califf continues to influence the future of medicine as an instructor at Duke. Now it says I can ad-lib a little bit now, Rob. So I think one of his greatest achievements was actually occurred, I think it was October 15th, right, Rob? Where he was inducted into the Royal Academy of Physicians of Ireland. And I know you get a chance to enjoy those courses out there too, Rob. So if anybody wants to check out YouTube, it's an amazing, amazing site to see Rob being inducted in Ireland. So now we're privileged to welcome Dr. Califf to Chair Chats, where he'll share his insights and experiences on fostering a more inclusive and equitable environment in healthcare and beyond. Now, before I introduce our Chancellor, Dr. Marie Lynn Miranda, we talked about this, that Marie Lynn has some tough questions, right? She's known to have tough questions, but I'm reminded that Rob went through 2 Senate confirmations, right? 2 Senate confirmations, and I know some of the people who questioned you. So I think you're going to be prepared, Rob, for this, for Marie Lynn. So Chancellor Miranda champions a vision centered on student success with a deep commitment to faculty excellence, transformative research, and innovation. Her leadership expands UIC's impact and deepens its engagement with the many wonderful communities that we proudly serve. She's deeply committed to accelerating the social mobility of UIC students and advancing the university's mission to provide the broadest access to the highest levels of educational, research, and clinical excellence. As she often reminds us, recruiting, retaining, and graduating students into the world with a sense of belonging and purpose is, without question, the top priority for UIC. Now, please welcome Chancellor Miranda.
Bob has done a wonderful job telling you a little bit about Rob, and we'll get into that in the Chair Chats questions. But I wanted to begin this afternoon by telling the story of how Rob Califf and I met. So I don't know if he remembers this, but I remember it quite vividly. I was an assistant professor. I was invited to a meeting of the academic health leadership at Duke, where I was on the faculty, and Rob was a prominent member of the faculty there. And somebody was giving a presentation and basically said, well, the problem is you can't figure out the answer to this question. And I leaned over to this random person who was sitting next to me and said, well, you can figure out the answer to that question. You just have to use geospatial methods to do it. And that person who was sitting next to me was Rob Califf, and I was like all enthusiastic about how geospatial methods could answer this question. And so at the end of the whole meeting, Rob said to me, so what's this geospatial stuff that you're talking about? And I, of course, had my laptop with me and pulled it out and showed him some of the maps that my research group made and how you could take the question at hand and bring these spatial data layers to play. And that was the beginning of a really, really great collaborative relationship. We've co-authored together, we've presented at various conferences, we've written grant proposals together, et cetera. And I'm very proud of the fact that he still uses some of the maps that my research group produced. And so Rob has been a really highly valued colleague for a long time, and he's also been a good and close friend. So I don't know why people keep telling you need to worry about how hard-hitting my questions are going to be. I feel like this is going to be a conversation that we're going to have together. For me, a conversation with a collaborator, with a mentor, and with a good friend. So Rob, if you want to join me on stage. All right, we're going to start at the beginning, my friend. So you were born in Anderson, South Carolina, and then grew up in Columbia. You went to high school in Columbia, I think. Tell us about Anderson and Columbia. What were they like, and how did those two places shape your views?
Anderson was just a place where there was a hospital. My dad was teaching at Clemson when I was born, so went over to Anderson to get born, and then came back to Clemson, where I lived till I was 5. And that had a big impact on me, because at the time Clemson was a military school. Not that long after World War II, my dad had been over in the Battle of the Bulge, and I used to love to watch the troops, student cadets marching on the field, and used to sit in the end zone at Death Valley and watch football. At the time, the booster society was called IPTE. I paid $10 a year would get you membership in the booster society. Now at Duke, as you know, it's $10,000 a year basically to be in that group. And then my dad, like a lot of people do, took to heart the concept that those who can should practice, and those who can't practice should teach. But ended up going into being a working architect in Columbia. I had to move down to where the Gamecocks were, and first question you get asked in school there is Clemson or Carolina. That's like the real rivalry. But I had a great life. My parents were pretty, I would say, intellectual and public policy oriented. We had a lot of good discussions. I had a chance to be captain of the state championship high school basketball team, which was the highlight of my career in anything. That next morning, it's like you're on top of the world, and then you go back to being a regular person again. So it was a good growing up. And I will mention, in today's political environment, I had a classmate all the way through junior high and high school named Lee Atwater, who some of you may know the name. He was really the architect of the Republican strategy, and I had a chance to actually in person have the discussions with Lee as that was developing. He went from wanting to be, this is a true story, from wanting to be a promoter of wrestlers in all-star wrestling. He used to spend every Saturday night at Township Auditorium in Columbia, where all-star wrestling happened. And then his freshman year in college, he met Strom Thurmond on the talk circuit and decided that promoting politicians was the same thing, just a lot more interesting and fun. And by that summer, we worked together the whole summer. He had worked out the Republican strategy, which had consequences for all of us thereafter. I didn't buy it then, I don't buy it now, but it's been fascinating to see how that one person had such an influence on the way others thought. That's sort of my South Carolina history.
Any early exposure to healthcare that led you to wanting to be a physician?
No. I kept, on the aptitude tests, they kept, back in those days, I don't know if they still do it. It was like every year I had to take some tests and I would get counseling on what I should be when I grow up. And it kept having physician high in the list. Lawyer was higher. But it turned out that my parents were pretty anti-medicine because I had a younger brother, and there was ABO incompatibility in the family. And the year that he was born was the year that Life magazine had the cover story about transfusion being an effective treatment for that. And my parents read the article and went in and talked to the doctor, who said, "Oh, that's just hooey." And my little brother died and could have easily been salvaged by this new treatment. Well, now when I look back on it, that would be a motivation to go into medicine, but to them it was like, can you trust these people? So I was going to be a clinical psychologist. I went north to Duke in 1969 as a freshman, and I ended up working 2 summers in the work release program in the state penitentiary, and that cured me of any desire to be a clinical psychologist. And it was only my senior year I decided that medicine would be a good career for me. I had the good fortune of seeing a person defibrillated early on in defibrillators, if you go back historically, and that was like a miracle to me. It's like you're dead 1 second and you're alive the next, thanks to Duke power, as we would say. And so I had to go back and take the pre-med courses my senior year and on into the next year. Took a year out and worked as an orderly in a hospital.
Okay. So I had to take those same aptitude tests when I was growing up, and year after year it told me I should be a mechanic. And I do like fixing things. Recently fixed our fridge, our dishwasher, my car. I do like it, but I like what I do even better.
Yeah, I think you're cut out for other things. But.
Okay, you went to Duke undergrad. You went to medical school at Duke. You then went out to UCSF for your residency, and then returned to Duke for your cardiology fellowship, and then joined the faculty and have had an affiliation with Duke ever since. So I think we can safely assume that you love Duke. After today, you're going to love UIC as well. That's my promise to you. While a faculty member at Duke, you started the Duke Clinical Research Institute. Explain to the audience what DCRI is and what made you decide to start it, and why and how was it important for the clinical research enterprise at Duke, and how is it a national model?
First, to be accurate, I have to say I have a love-hate relationship with Duke, and I can tell you all the things that are wrong with it, which is part of my nature, as you know, but I do love it, and as you know, this was the centennial year, 100 years of Duke University, and I've been affiliated with the university for over half of the entire life of the university. So it's a deep relationship with all of the complicated aspects that go with that as you think about your career and all the people that you meet. But the founding of the DCRI was really a happenstance of the fact that I'd come along as a medical student, and Duke has this unusual curriculum where you spend the whole 3rd year as doing research. At the time, research meant going into somebody's lab and doing bench research, but I already knew that was not what I wanted to do. And some people stood up for me, and I was allowed to do human research. Because at the time, some prescient people at Duke had invested in computers, thinking they would be important in medicine. Now, as you know, at that time, 1978, 76 through 78, all the medical records were handwritten.
Right.
And so computing was not really a part of medical care except for the beginning of physiologic monitors for things like heart rhythm. And so I started doing research integrating computer science, medicine, and biostatistics into clinical research. And the very first study I did as a student was putting Holter monitors on people. Another amazing thing, it was 1978 when Holter monitors first became available. We had predicted that measuring ambient arrhythmias would predict the risk of sudden death, which was a big problem. At the time, men especially were smoking a lot and they were dropping over dead. That's a problem. So we put on the Holters and measured a bunch of other things, and lo and behold, it turned out it wasn't the ambient dysrhythmias, it was left ventricular function that predicted the risk of sudden death. I was actually ridiculed when we presented the results because no one believed it. And all that happened was we collected the data and did a proper analysis, and that's what it showed. And I guess we turned out to be right, because if you think about what merits an implantable or now a leadless defibrillator, it's really the left ventricular function that's a determining factor over when the device is useful for preventing sudden death. All right, then I went off to UCSF, did my house staff. That was great, and I love San Francisco also. Came back, and the year I took over the coronary care unit was the year that the first angiogram was done of someone having a heart attack. And I had been taught that blood clots didn't cause heart attacks because there were no living examples, and it was all based on autopsies. And when you die, there's endogenous fibrinolysis occurs, and there are no clots sitting in the coronary arteries. But the angiogram couldn't be more clear. And then the race was on to develop treatments for this leading cause of death. I had access to computing that other people didn't have. And we had a network of friends that had been house officers. Many of you probably read books by my intern, Eric Topol. And we had a whole crew of people who went into cardiology fellowships. So we said, we don't know how to treat this problem. Let's work with industry that's developing products and figure out which ones are good. So we started doing clinical trials. That was going along kind of nicely as a cottage industry, and literally we had a group of friends. We would enroll people in the trial, then we would meet together and figure out what to do next. And then the Europeans did a big study comparing a very inexpensive way of opening arteries with a streptokinase with the American biotech drug being the comparator, TPA, and it was a dead heat. There was no difference. So this was really the beginning of the American biotech industry, and it was under threat. We had figured out that you needed to dose the TPA in a different way in the studies that we had done. And so they needed to do a large trial. I'll never forget the day they came to us and said, we'll pay for an adequately sized trial. Let's figure out what it is. We did the sample size calculation. 30,000 was the number. And so in the course of a few months, we put together 1,000 sites in 15 countries, and it turned out we ended up needing 40,000 people to do the trial correctly, and got it done ahead of time and under budget. And so at that point, we had a coordinating center, and it was so obvious that much of what we do in medicine is sort of based on how people feel, and you're sort of putting together pieces of information, but you don't really know. And clinical trials were a way of figuring out in any field. So the university backed us up to create the Clinical Research Institute to do this across fields. And it's thought of as a clinical trials operation, but it was equally based on what we today call outcomes research, because the basis of it was collecting data about people in computers and measuring what happened and then figuring out standards of practice and the best thing to do. So that's how it all got started, and then all the trouble started after that.
So what work from your time as a faculty member are you most proud of?
I mean, for me, it's, I never thought that I was very smart. And so for me, it's always the people that came up through the system who went on to do better things than I could do. And, you know, there are a number of those scattered around. I run into them all the time. Maybe as much as the people who have excelled in research, I was a very busy intensivist rounding in this extraordinarily busy coronary care unit at the time. And I'm telling you, I go through airports today and people bump into me and say, hey, I rounded with you 25 years ago and you said this thing and it changed what I decided to do after that. Hopefully it was in a good way. But that's the kind of thing that makes me feel good. There's no individual accomplishment that I'm most proud of. The funniest one probably is I am the recipient of the Ig Nobel Prize.
Yes.
So not many people can say that. I know I'll never win the Nobel Prize, so the Ig Nobel Prize is a good second.
Yeah. So I'm hearing a lot of themes about relationships and the importance of nurturing positive ways of interacting with people to be able to get more done and to also have more fulfillment and happiness, shall we say. Okay, you did 2 stints as commissioner of the FDA. How did you first come to the attention of the Obama administration? And what was the vetting process like? And what motivated you to serve as the FDA commissioner? Why did you want to do that?
Well, you know, in my work at the DCRI, a lot of the studies we did led to indications or new approval, or in most cases actually not being eligible for approval, because most of the trials that I led were actually negative, which is a very important lesson. But there were a lot of interactions with the FDA that occurred, and I guess by nature, although, you know, I was a mediocre athlete and loved to play basketball, by nature I'm more of an evaluator than I am a participant, and I really grew to admire the mission of the FDA, which is to dispassionately look at data and make judgments about the balance of benefits and risks of products. And the science of doing that, I thought, was just the right way to do things. So I'd always had these interactions. I was asked twice to interview in Republican administrations because I'm kind of a, I don't know, middle of the roader politically. I think both sides are crazy.
And you wear a bow tie.
Yeah, that's true. But I couldn't make it because I'm not anti-abortion. And that was a litmus test at the time, both times that I came through. But, and I had sort of not had an aspiration after that to be at the FDA, but it turned out Peggy Hamburg was a commissioner that Obama initially appointed, and 6 years into the job, she decided that she had done her service to society, and she literally flew down to Durham and came to see me and said, you should be the next commissioner, but there's a slight problem. I can't make you commissioner. The president has to ask you to do that. And at that point, you know the complexity of Duke. I was ready to do something else, and so I agreed to go to Washington as a civil servant, which was I had a whole year of being deputy commissioner, which is a full civil service job. It was a great year. I had a tremendous time. And then I got a call in the middle of one day saying, someone needs to brief President Obama on the error rate of whole genome sequencing, because the All of Us study was being planned at the time. And I said, that's great. How many weeks do I have to prepare? And they said, you have till tomorrow at noon. So I ended up in the Roosevelt room with the whole NIH team and others and made the presentation. It was amazing because a lot of people don't know this, but Obama is a very quantitative person. Very unusual for lawyers, in my experience, to be so quantitative. He had already read all the materials, and the whole discussion was about what was beyond the presentation. So I got a call that afternoon saying, come to the Oval Office the next day, and he asked me to be his commissioner. After 15 minutes of argument about Duke and UNC basketball, he's a huge Tar Heel fan and still is,
But his body man was a Duke player.
Well, that's part of the problem, because he and Reggie Love at the time, Reggie was his body man, but they had a real rivalry in one-on-one basketball. So it didn't help. But anyway, we came to agreement, but then as I walked out, there was an army of handlers out there saying, okay, he asked you, but you're not commissioner unless you're confirmed by the Senate. And that afternoon, they took me to see 3 senators, all of whom told me they were not going to vote for me, blamed me for the opioid crisis because I had worked with pharma in the clinical trials that we did. And that was an initiation into Senate confirmation. We eventually got through it. It took a number of months, and there are all kinds of stories that go along with it, but it happened.
Okay. So here's a question from our Dean of the College of Pharmacy. What was the most difficult or controversial decision that you made while FDA commissioner, and why?
I would say the most controversial was the Sarepta decision. It wasn't the most difficult. It was a relatively easy decision for me. What had happened was you had a company that had made an intervention for a rare genetic disease, Duchenne's muscular dystrophy, with a biomarker of production of protein as the endpoint. Mm-hmm. They screwed up the study. There was an academic institution that I will not name, but you can find it easily, that had an assay that was not reproducible. The trial got finished. The internal team at the FDA concluded that it did not meet the criteria for approval. But Janet Woodcock, the head of the drugs part of the FDA, the top civil servant in the chain of command, overrode them because she had sort of been through the whole study all along and felt that they were being too conservative in the setting of a rare disease with no treatment. And the internal team was so mad they appealed it. And the appeal process goes to the chief science officer, who agreed with the internal team. And so by law, that then comes to the commissioner for a decision. My decision was to say there's a reason why political appointees like me should not be making decisions about individual products, and the top civil servant should only be overruled if the person has a mental health problem or they're corrupt, and neither one was true. It was a matter of judgment. I still haven't said anywhere publicly, and I will not, what I would have done had I made the decision, but the decision was to say this should be made by the civil service. There were a lot of people who disagreed with what I did, but fast forward to today, I think it was a really important precedent that I hope we'll go back to, because the minute political appointees start making decisions about individual products, where do you draw the line over political influence, over what gets on the market and what doesn't? Mm-hmm. I regard the job as a commissioner mostly to block political interference from affecting the function of the civil service, which is there to make these decisions about risk and benefit. The one I regret the most is that I could not get the tobacco stuff across the line. And it's still right there with hypertension for the leading cause of remediable death in the U.S., and I failed the second time. I had a full shot at it the second time around, knowing I was ready, and I could not get it across the line. The issue is that by law, the FDA cannot outlaw nicotine, but it can set standards for what is allowed with nicotine, and it also can regulate the types of flavors used in tobacco. But to get that through, you had to get through the whole of Health and Human Services and the executive branch, and had to fend off all sorts of political trade-offs that would have occurred had it gone through, and frankly, we just lost. Mm-hmm. The second time was particularly painful because we were trying to get a rule through that made it illegal to market menthol tobacco, which is specifically marketed for African Americans in particular and has killed a lot of people. But Al Sharpton came up against us, and I was no match for Al Sharpton in the political arena. And we have figured out, and it is known, what the addictive level of nicotine is in a product. And so we had a rule that would have limited nicotine to a sub-addictive level. And it's pretty clear that not many people would use combustible tobacco if they were no longer addicted to nicotine. But that was held up until after the election, and by then, all we could do was a proposed rule, not a final rule. And the Trump administration, of course, invalidated it immediately upon coming in. So at least we've got all the documentation there for people to read if it happens. But in terms of public health, that was the number one issue where I think we came up short.
Okay. You know, we were at the Economic Club of Chicago dinner last night where Dave Ricks from Eli Lilly was speaking, and he was asked this question, and I'm going to ask you the question. I suspect your answer will be a little bit different. So what can be done to lower the cost of medicines in the United States and globally?
Yeah, so first, let me just say that it's really important to distinguish when you say medicines, medicines that are still under patent and medicines that are generic. When we talk about the United States, the prices of our patented medicines are way too high, in my opinion, but the prices of our generic medicines are too low. We pay a lower price for generic medicines than any other high-income country. And the price of generic medicines, particularly the most inexpensive, are below the cost of production and distribution. So I want to spend a second on that because I think it's really important. And the control of it is actually in your hands. Because my version of the history is that the Hatch-Waxman Act that created this period of patent protection and then you go generic was a brilliant piece of legislation that's done a lot of good. 94% of our prescriptions now are generic, and that's a great thing. But how do generic medicines get made and distributed and bought? They're bought by health systems through group purchasing organizations that I say you, just for fun, originally put together and then decided they were so valuable that you made them for profit and sold them to get the cash that came from it. So this is health systems in general, not you specifically.
It's a fair criticism.
And your purchasing agents and your GPOs get highly rewarded for getting the lowest price possible. And now we're in a global market, fast forward to a global market. No one in the U.S. can afford to make these products for the prices that are offered, so the whole thing moved mostly to India and China for different components. And Indian companies are well known as a standard business practice in other commodities to underbid in order to get the business, and then you raise the price to reach a reasonable level. But what's happened in this industry is the contracts with the GPOs are one-sided, so they can drop the manufacturer at any time, but not vice versa. So the result of that is a race to the bottom. The prices go below the cost of manufacturing, even in India. And so then who wants to be CEO of a company that makes a drug that's guaranteed to lose money? So you wonder, we have hundreds of drug shortages every year now. They're all in low-cost generics for that reason. And it really actually is in the control of health system purchasing organizations. In other industries, the purchaser oversees the quality of the product that's being bought, not the federal government. So the FDA has a role there when there is a shortage. Our people, we're all over the phone trying to get people to make something that would not make a profit. It's not a fun thing to do. All right, so that's that. The patented medicines, there's just been an unfortunate misallocation of bargaining that goes on because lobbying, as best I can tell, lobbying led Congress to make it so that the government, our largest purchaser, doesn't really negotiate on price. And so the result of that is that the industry can get sky-high prices in the United States, and therefore it doesn't need to negotiate in the rest of the world the way it could. So Asian and European countries get a real good deal, and we pay a higher price in this country. Now, there's some aspects of this that have secondary benefits to the U.S. It creates a lot of high-paying jobs, and it gives us prowess over what these companies do, because this is where they make their money. But it's not fair to the average American who's paying much higher prices than they should. you can tell I wasn't too happy with Dave Rick's answer, although he's a good friend, and I think, if you look at the work that Lilly does, it's phenomenal. It's a phenomenal business that's very well run and in general has done good things for society. But this is an area, it's hotly contested. There are many opinions. You've just heard my view of it. I think we should negotiate. It may be the only place I agree with Donald Trump about anything. We should negotiate harder with Europe and get Europeans to pay a fair price and then drop the price in the U.S.
Okay. Before your first stint as FDA commissioner and between your two separate stints as FDA commissioner, you worked at Google Verily. How did your involvement with Google begin? How did you use your training to shape what's happening at Google, and how did you use your time at Google to shape your second stint as commissioner?
Yes, there was a small group of us who were perseverating about the ills of the American healthcare system 20 years ago. And here's what we thought. We said, this is all about information. There are only a few companies that have access to the world's information. They're evolving rapidly. They're not really involved in healthcare or, for the most part, in health the way we normally think of it. So we said, let's get together and go to Google and convince them that they should get into healthcare. And we did that. It turned out that at the time, the founders who were very involved in this, I think they were actually scared. They're so young. They were so young at the time. I think they were scared of healthcare. The idea that people would be sick is something they didn't really like, and they were making a lot of money doing other things. So they fired us after about 4 trips out to Google and actually never paid us for our trips out there. That was okay. But then they asked one of us to come back when they decided to form Alphabet, which was basically, in order to start new things, they said, let's form an umbrella corporation where Google is the revenue source, but we'll create multiple new companies that will do different things and information. And, so Waymo is the one right now that I think a lot of people are talking about that's on the verge of being very successful, in my opinion. So they asked one of us to come back, and then when Trump came in and I came out, he called me and said, hey, we're here now. Let's get started. And I was also attracted because I'd become convinced that addiction to social media and the addictive circuits were a real source of bad health and badness in society. I thought maybe some smart people at Google could figure out how to reverse engineer that process. And so I got to do a lot of crazy things related to health and healthcare, and I got to work on that problem. What I learned was you can't reverse engineer this. No one knows how to do it. The closest thing to it is actually what we talked about last night with Dave Ricks. It turns out the GLP-1 drugs do something to these addictive circuits that causes them to change. But we did a lot of crazy things in healthcare, most of which didn't work, but led to a lot of interesting ideas. And it wasn't because of, I didn't go back to FDA because I intended to. I went back because the president called and said, we can't get anyone to take the job. It was in the middle of the pandemic. And, you knew it was going to be a thankless job. But by then I was 70 years old. I didn't really care about that. And it was a chance to serve in something I thought was important, so I went back. And I was all ready to use what I had learned at Google in this interaction with the public. But what happened there was I learned that it was illegal, according to the current court system, for the FDA to use the tactics that are actually successful in interacting with the public about topics. We were our most successful...
Can you say what you mean?
Yeah, so our most successful communication was a tweet. It was before I came back, and it said, don't be a horse, don't be a cow, don't take ivermectin. And the problem that was being, and it had nice visuals, it was a meme, and the problem that was being addressed was we had a lot of members of the farming community who were taking their animals ivermectin at wrong doses and having serious consequences. And it went viral. It got a lot of attention. It got the message across. But a group of doctors who are part of the medical freedom movement took us to court and we lost. And the court said federal agencies should only be communicating with fact-based information in standard format. The FDA is not your doctor, was actually a quote in the court decision. That was the infamous Fifth Circuit of Texas, which is where all those cases go there because it's known what they're going to say. But then we had a decision to go, and I was at FDA when we had to decide what to do. But the worry is if we took it to the Supreme Court, we could end up with a judgment that could invalidate a lot of what the FDA was doing. So we let that sit. So we're in a situation now where people promoting unreliable information have a real advantage over federal agencies when it comes to health and healthcare.
Okay, so you said earlier, unless the civil servant has mental health issues, has a mental health problem, or they're corrupt, political appointees should not be overriding. And I'm just going to ask a very open-ended question. What is going on with vaccines, and why are they such a flashpoint now?
Yeah, so let me make one adjustment to what I said, and I want to be clear about this. I think I said it right the first time, but just to emphasize the point, political appointees should be very involved in policy making.
Right.
That is a political process. What I'm talking about is decisions about individual products. So think of the FDA as a referee in a sporting event where the rules are set by, first of all, laws that Congress passes, and secondly, executive branch rules which have the force of law, but which may be suggested by the FDA, but are actually made through HHS and the President's office. And so then the FDA uses those rules to make the calls. It's like blocking and charging in basketball. You know, the rules are there, and there's some leeway and points of emphasis, but the FDA is really a referee in that process. And in theory, and usually in practice, the civil servants, but since they can have no financial conflicts of interest, are there using those, applying those rules to a set of data and facts to make a decision about risk and benefit. The minute it's open to, but making those rules is a political process. That's, the commissioner has a huge role there. The minute you open that up on the individual product to political appointees, they are by design visited frequently by commercial interests or other interests. You know this, but one of the most powerful lobbies in Washington is the academic medical center and the university lobby, because you account for such a high proportion of employment in congressional districts, the politician's going to listen to what you say. So it's all types of influences that can occur. So what's happening with vaccines is you have a politician who was appointed the head of Health and Human Services who is frankly an anti-vax person. People call him a skeptic. He's not a skeptic. He's basically opposed to vaccines and thinks that they're bad for people. And he's exerting every bit of political influence he can to do everything possible to make it difficult or impossible to give vaccines in the United States, and doing it very directly and unashamedly. Here's where I need to give my spiel. I've been a political appointee twice. I'm 74, I'm not looking for a job, and I'm not looking for an NIH grant. So I can, you know, I'm saying what I think.
You are free, my friend.
I'm free, you got it. So I think people need to realize that this is not someone who's weighing scientific evidence. He's practicing what I call policy-based evidence instead of evidence-based policy. The standard would be that you have a question, you do the research, you may need to even do clinical trials, get the answer, then you make a policy. What he's doing is he has the answer, then he dispatches the scientists, and if they don't bring back the answer that he wants, they get fired. And if you look at the people that have resigned publicly from FDA and NIH and CDC, you'll see that common theme is they were bringing back answers that he didn't like. And there is no future for you in that organization if that's what you do. So it's a difficult situation.
What's our way forward?
What's our way forward? We have elections. Elections have consequences. That's one. I think it's really important for the biomedical community to speak with one voice now in policy circles. There was a chance for RFK not to be confirmed, and Senator Cassidy specifically, who had spent his career working on hepatitis C treatment and vaccine, has, caved and voted for him, although I believe that he knew better. So that's policy circles. But there's another area where I think we need to wake up at universities and in established medicine, and that's the arena of social media. Because ultimately, I think this administration is sensitive to perception. You could argue about in which segment of society and that sort of thing. But in general, making bland statements or putting out press releases, writing journal articles, that is a losing proposition in the current social media scene. And we're getting beat.
Right. We need to cut through the noise.
Yes.
Yeah, agree. In the age of digital health and increasing use of AI, this is from Amanda Corona, what are your greatest concerns or hopes with the use of these new technologies and their impact on equitable access to healthcare?
Well, it's pretty well known that the major use of AI right now in healthcare is to separate people from their wallets. That is, to distinguish people in whom you make money versus people in whom you don't. We call it payer mix and use other terms like that. What we're really talking about is, if I take care of your health problems, I'm going to get paid and make money doing it. And almost every clinician I talk with, and I haven't talked with your rank and file clinicians here, so I'm not going to make any statement about UIC, but everywhere else I go, and including our best academic institutions, practicing clinicians are telling me they're under intense pressure to generate margin by doing more RVUs, and every administrator has a list of procedures and RVUs that make money and those who don't. And every planning office looks at techniques like geospatial maps to figure out where to put clinics in places that make money. And we need to change that. And so the sense I'm getting now that I'm a free person again is that if we all recognize that in healthcare delivery, we have to balance financial imperative. You can't lose money and stay in business because all of our people want to get paid, and that's perfectly reasonable. If we have to balance that with professionalism and the well-being of the people we're supposed to be serving, we actually have to explicitly talk about the balance. And what I'm hearing from everyone is right now, this is what we're seeing. A huge emphasis on finance, not a lot of right discussions about the outcome of the population. What's my evidence? We spend $5 trillion a year in this country on health care. We have the worst longevity of any high-income country by far, and the gap is widening as we speak. So we're delivering a lot of services and don't have a lot to show for it compared to countries that are don't spend nearly as much money and far inferior to us. So the hope for AI is that, I think you're a mathematician, I'm not, but I've always worked with mathematicians, and I think about AI as it's like any equation, it's just got a much bigger thing on the left-hand side, all this stuff, but it equals something. What is it you're solving for? If we're solving for optimizing finances, we'll keep going down the road that we're going, which is one in which if you have a college education, you live 8 years longer in the U.S. than if you don't. The biggest determinant of outcomes now, I think, is aggregate wealth. Even if you're undereducated and you're wealthy, you do quite well on average. We can keep going down that road, or we can change the variable on the right-hand side of the equation to some true multivariate equation, which is a balance of finance and outcomes. And so my great hope is that we'll do that, because if we ever did that, AI would actually solve for it, and it would be telling us to do something very different than what we're currently doing in our healthcare system.
Well, you know, the thing about AI is really good at solving for the problem that you pose to it. And the question is, what problem are we going to pose to it? And I'm going to say to you that the way that you described health systems in general is really not how we practice medicine here at UIC. It's one of the reasons I feel the most pride in being at this institution. So we certainly have to pay attention to revenue, but one of the ways that we pay attention to revenue is thinking about this group of patients would be eligible for Medicaid. We're going to treat them, and we're going to help them get enrolled in Medicaid, as opposed to saying we're going to treat them and figure out how to make sure they never come back to us again. So we do have a focus on revenue, but I see some of our docs in the audience. The minute at this institution you told our docs that, you know, we have to fundamentally shift our payer mix away from the most vulnerable people in Chicago, is the minute we would lose our best docs here at UIC, because they're so deeply committed to our mission. So I'm hoping you'll get a chance to speak to some of our rank and file who will tell you about that commitment to mission. It's a very special place here.
And I mean, don't get me wrong, I'm not saying that this is an easy situation.
It's
you
not.
have to be able to pay the bills. But we also have to recognize the larger context in which we're working.
Right.
So,
Particularly with the proposed Medicaid cuts.
right, and so you're saying that you go out of your way to try to help people, but they're trying to navigate a system which is actually designed at the start to produce inequities. And so my hope is that if AI is deployed correctly, it will just make it impossible to ignore what's kind of obvious to begin with, but pretty easily documented, that if the goal was to improve health, you would be doing a very different set of activities.
Yep. So you have more than 1,200 research publications. Who is your favorite co-author? Is it, say, someone who made you beautiful maps that you've used for decades? Just wondering.
Well, I enjoyed writing some papers with you. I still show them in talks that I give, so you rank up there. But I really like to write papers in general with quantitative people where we can go back and forth, because oftentimes the quantitative people are not experts in the medicine part of it, and I'm not a quantitative expert, so to me that leads to the most successful publications. I also have to say I've always used editors, and I just find that to be tremendously helpful. I always write the first draft if I'm the primary author, but having someone who knows your writing style, who can tell you that was a stupid sentence or this didn't make sense, is tremendously helpful. But I'd also say it's fun writing papers if you have a group of people who want to work through a problem and understand it.
Yeah. So I remember the first paper we wrote together, when you send it to an editor and we got the comments back, I was like, this editor thing is awesome. The other thing that I talk about this regularly, and I attribute having learned this from you, which is you are a person who, when people come in hot and they have their critique, I have always observed you to just, whatever hot level they were at, your response was calm and down here. And you listened to the substance of what they said, and you responded to the substance of what they said and not the tone in which they offered it. And I think that was the most important leadership lesson that I learned from you. I'm really grateful to you for that. So.
Well, thanks. I attribute a lot of that to running intensive care units, where you just have to keep equanimity to deal with the patients and families, and often the staff, in times of stress, as a way of functioning. But this was a real problem for me politically, because I constantly had people telling me, you have to look hot in order to be successful politically. I just can't do it. You know, it's not in my nature, but
I've never
hopefully-
seen you do it, never.
No.
Okay, and a consistent theme in your work across all your roles has been an emphasis on health equity, including equity in clinical trials. And all the work that we did together was all around health equity. And that's something we're well known for here at UIC, from running 11 federally qualified health centers to the portfolio of research that we have here, the people we see in our clinics, including in our dental school, and combining questions from multiple people in the audience. What can and should investigators be doing to improve equity in clinical trials? And what are you doing now to champion equitable access to health care?
You probably won't be surprised by the first part of my answer, which is you have to work as hard as you can to change the system in which clinical trials are being done. Mm-hmm. If you're operating a system which is designed to produce inequity, then you say, we're going to fix it by doing clinical trials that are equitable. That's asking a lot of clinical trials. Mm-hmm. In other words, just as an example, if you look at diabetes and you look at the number of people that are living in places where you can't get to an endocrinologist without driving for 2.5 or 3 hours, it's a lot of people. And then you say, well, we're going to be equitable in our enrollment into diabetes clinical trials. Seems like that would follow if you actually had a system that delivered the services to people that were proportional to where they live and the need that existed. But having said that, you know, the first step in clinical trials is awareness and acknowledging that it is an issue and then planning for it. In our much discussed guidance from FDA about clinical trial diversity, the main point of it was everyone who does, if we're talking about prospective clinical trials, everyone who does them goes through a planning phase where you simulate what the trial, how the trial is going to be done and what it shows. Simulation may just be a discussion and a, you know, written protocol, but often now it involves pretty detailed quantitative estimation. And so, and it's not just about race and ethnicity or sex, it's about all the characteristics of people. And you would like your trial to be representative of the population that's likely to be affected by the result of the trial. In the case of a medical product, that means the people for whom the product would be prescribed or used. And that can include all sorts of other things that are dependent on what the product is. Body size may be important, age may be important. All those things are factors. And rather than just focusing on one part of it, we ought to be saying, we do a clinical trial because it's a sample of a presumed population, and you want to extrapolate from that sample to what's going to happen later. That's the point of it. So plan on it, and then follow through. Those are the things that need to be done. Now, I recognize that's a big challenge right now when you can't use the word equity or diversity in your planning. And, you know, we're all going to have to figure out how to deal with that era for some time. And, you know, also just want to put in a plug for the characteristics of wealth, which you're dealing with. Rural status is a huge factor right now, and a tough one because, like I said, if you don't live near a center with the right expertise, and so we have sightless trials and various other methods developing. And I can't resist, I want to put in a plea for men right now. Men are in, if you look at the statistical trends that are occurring in our population, young men in particular are not doing well. And it's a rapidly evolving trend, very high suicide rates, lots of them in basements doing video games and not actually interacting with people, and risk factor profiles that are going out of control. So one of the things that, I mean, you know me, so one of the things, and just in terms of it, I feel like we always have to adapt and change. We're sort of stuck in an old view of disparities, which needs to continue because those are still playing out. But we've got these new trends, which if we don't wake up, we're going to find ourselves in a whole different set of terrible problems with. So if all you did was say, I'm going to do, let's say I'm developing a new ventricular defibrillation device, you'd say, who's likely to get it? And then you say, let's do a clinical trial on the people who look like the people who are likely to get it or who should get it.
Yeah. So I just was unexpectedly out of town for a number of days taking care of a male family member who was in the middle of rural America, hospitalized, and you know, your emphasis on rural healthcare and making sure that we're able to provide the quality of care that we need everywhere in the United States, and thinking about how we connect centers of excellence in other locations, whether it's through telehealth or other kinds of partnerships, is much on my mind these days, having now come back the 800 miles from where I was.
I mean, we all know that if we can integrate digital techniques with AI and human care and get that right balance, it's an amazing time where so many things are possible. But if we don't have the right values to start with, you know, another great example that's playing out right now, all that money was allocated for high-speed internet all over the United States. Almost none of it got used for that. And so Wall Street Journal had a great article on this that showed the map of people that don't have any doctors living in their county and internet access in those counties. And it's the very counties where you wish you had high-speed internet where it doesn't exist.
Right. Yeah, so we have a farm in Northwest Indiana, and I always say the reason that people in rural America believe that the center has forgotten about them is because the center has forgotten about them. So my download speed is 0.5 Mbps at our farm. Okay, for your first stint as FDA commissioner under Obama, you were confirmed by the Senate by a vote of 89-4. For your second stint under Biden, you were confirmed by the Senate by a vote of 50-46. And Marty McCreary was most recently confirmed by the Senate by a vote of 56-44. Your second confirmation vote and McCreary's was mostly along partisan lines. Those are really big swings from your first to your second and McCreary's. How do we combat the devolution of what used to be scientific decisions to what are now political decisions?
Well, first of all, let me just say, I don't feel that FDA commissioner was ever a scientific decision. And in fact, all those jobs at HHS, they're political jobs. They involve science. But there was a time when bipartisanship was part of politics. And that's what's changed. Specifically, what happened in my case, things were going great the second time around. One reason that I got called by Biden was that I'd had that, you know, big vote the first time, and people didn't seem upset by what I had done. And Richard Burr, who you know, was the main person, a Republican, who was pushing me through. But then the Susan B. Anthony Foundation, the second time around, put out a press release saying that any Republican who voted for me would get primaried because I was not anti-abortion. So that day, I got calls from a number of senators saying, I look forward to working with you, but I'm not voting for you. These are all Republicans. So I called Richard and I said, well, it looks like it's over. This is great because my family didn't want me to go through this again. I've done my duty. I'll see you later. He said, no, don't hang up. He said, I'll get you the votes you need, but not one more than you need. And that's what happened. It was a political. But and again, I want to distinguish. I do think the history is extraordinarily strong, that the one reason that we have such great medical technology in the U.S. is because the FDA decisions about individual products have not been political. The policies, though, are completely political. They're a product of a process of lobbying, interaction with federal agencies, more lobbying, and then a vote either by Congress or someone at Office of Management and Budget and the executive branch. And so I just think there was a change in politics, not that it went from being scientific to political.
Okay. So one thing, you made mention of this just now, one thing I know from our many years of friendship is that you are devoted to your family. And we always ask women leaders this question, and I am in the habit of asking male leaders this question. How did you balance your commitments to family and to work?
Inadequately. You know, I was fortunate, as you know, I married someone who was a high school sweetheart, was still married 52 years later. It hasn't always been a pretty sight. And there were phases where I was just totally devoted to work, and she tolerated it mostly. I wouldn't say that she thought I did a great job during those phases, or that she was particularly happy with the marriage, but we stuck together. It did make my day. About 15 years ago, we were at our annual Beaver Creek cardiology meeting where the whole family, a bunch of families would go. And I woke up one morning and there were all three of my kids sitting at the kitchen table with their computers out doing their work. Mm-hmm. And I thought, how many times do you tell me to stop working? And here you are doing this. But, you know, I think the balance is different for different people. And I'm now in a phase of life where I can give back. And, you know, we have 6 grandkids, and I'm spending time with that. And I think our marriage is really strong, which I'm proud of, because it's not an easy thing to stay married under any circumstances these days in this country for a long period of time. But I would not want to be the person giving advice on work-life balance. And you know, if I go one step further, I'll just say it. I think there are situations and times where you have to make a decision. Am I going to have work-life balance, or am I going to do something that's extraordinary? Because it's not always that you can do both. Mm-hmm. And I don't object to a decision either way, but I think when people are ambiguous about it, that's when trouble really occurs, because you're unclear with your family about what you're doing, and you're not delivering on what you promised. You think about startups, and I've been involved with a number of startups now. They don't succeed with a work-life balance CEO for the most part. You have to give your life to that for some period of time. In politics or public service, there are times, if you looked at FDA employees during the pandemic, and I know many of your clinicians were in the same boat, it was 24/7. Right. It wasn't a balance with families, but there was a great need of society. So I would not hold myself up as a model, but I've been lucky.
Well, I know your wife. I think you are lucky. She's really wonderful. So, you know, it's interesting. When asked that question, I never talk about work-life balance, because I always say my work is a very important part of my life. But it's balance, and the notion that that balance changes at different points. And sometimes one person is carrying a heavier load, and sometimes another person is carrying a heavier load. So I will say my husband is currently carrying a much heavier load in our family than I am. But we are both enjoying our own first grandchild. So,
all right.
Yeah. So thank you so much for joining us today. We very much enjoyed hosting you on campus. I'm hoping that you leave here with a better sense of how it's possible for a health system to be fully committed to serving everyone and providing world-class care to everyone. When we say we treat everybody who comes to us, it really is true. We treat everybody who comes to us. We have a small token of our appreciation to commemorate our time together at UIC. I think Dr. Barish is going to come back to the stage to present there's something down here.
Something down there. Okay,
there's something
great.
Down here, my friend.
Well, let me just say I really appreciate the chance to be here, and I want to thank Jerry Krishnan, who originally asked me to come to, as was pointed out, to his event, and then it became a larger event. It's been really interesting and fun to meet so many people, and thanks to Ralph also.
Maybe we can stand up while you're... All right.
Okay.
So on behalf of UIC, and where's Jerry? And as part of the the Dean's Distinguished Scholars Series, as well as the Chair Chat Series. We're very delighted to present you with this weapon. It can hurt someone that's got a pointy thing.
I think I can get through the airport with that.
I think you can. So thank you so much for
you.
being here.